Let's talk about hepatitis A, E, and D. Hepatitis A is a small non-enveloped RNA hepatovirus. It is exclusively a virus of humans and primates. Its virome consists of 4 caspid polypeptides designated as VP1 to VP4, transmitted by fecal-oral route, absorbed in the small intestine and replicates in the liver. HAV is secreted in the bile and shed in pieces for 1 to 2 weeks before clinical illness and approximately 1 week after the onset. Incubation period is 15 to 20 days. On an average, it is 30 days. There is no chronic carrier state. Inactivation of viral activity can be achieved by boiling for 1 minute, by contact with formaldehyde and chlorine, or by ultraviolet radiation. Its replication is limited to the liver, but the virus is present in bile, stools, and blood during the late incubation period and acute pre-symptomatic phase of the illness. Clinical features is often asymptomatic in children. May begin with non-specific prodrome of fever, malaise, weakness, anorexia, nausea, vomiting, arthralgia, myalgia, and upper respiratory symptoms. It is followed by 1 to 2 weeks of dark urine, jaundice, mild pruritus, and slight liver enlargement and tenderness. Labs reflect hepatocellular injury and aminotransferase levels may be elevated between 500 to 5000. Serum bilirubin usually peaks later and then transaminase levels but remains less than 10 mg per deciliter. Most patients have normalization of LFTs within 6 months. What is relapsing hepatitis A? Recurrent hepatitis secondary to primary infection. The severity of symptoms and biochemical abnormalities during second phase tend to be the same as observed during the initial illness except for tendency for greater cholestasis. The rate of hepatitis A relapse varies in different case series from 1.5 to 11.9. Diagnosis requires presence of serum HAV IgM. IgM antibody persists for 3 to 6 months after onset of symptoms. Anti-HAV or IgG after acute illness. Hepatitis A is a typical serological course. The fecal HAV starts to rise by 0 to 1 months after exposure. ALT and total anti-HAV starts to rise around 1 month after exposure. The IgM anti-HAV rises and there is a fall by 6 months. There is no treatment. Prognosis is usually benign course in young, healthy people and associated with low mortality. Over adults, immunocompromised patients and those with chronic liver disease have greater morbidity and mortality. Mortality is 0.1 to 2%. Immunoglobulin, prevention is immunoglobulin available since 1940. Immunoglobulins administered low dose provides protection for 1 to 2 months. Inactivated HIV vaccine available since 1992. Post-exposure prophylaxis, close personal contacts, household and sex contacts, persons who have shared illicit drugs with someone with hepatitis A, childcare center staff, attendees and attendees of household members, persons exposed to a common source such as infected food handler. If a food handler receives a diagnosis of hepatitis A, post-exposure prophylaxis should be administered to other food handlers at the same establishment. Healthy persons aged 12 months to 40 years who have recently been exposed to HIV and who have not been vaccinated previously should be administered a single dose of hepatitis A vaccine within 2 weeks after the exposure. For persons aged in 40 years, immunoglobulins are preferred, and for children less than 12 years, immunocompromised patients, persons with chronic liver disease, and persons who are allergic to the vaccine or vaccine component immunoglobulin should be used. So for pre-exposure prophylaxis, indications for HIV vaccination, people planning to travel to endemic areas, men who have sex with men, illicit drug users, people with chronic liver disease and recipients of clotting factor concentrates. Hepatitis E. Hepatitis is a small non-enveloped single-strain RNA virus, can infect human, primates and swine. Transmitted by fecal-oral route, thought to spread zoonotically, principally through swine. Absorbed in the small intestine and replicates in the liver. It's secreted in the bile and shed in feces for 1 to 2 weeks before clinical illness and approximately 1 week after onset. Incubation on period on an average is 40 days. There is no chronic carrier state. The clinical presentation is similar to HIV. Relapsing hepatitis is rare. Diagnosis requires presence of serum HEV-IgM and acute infection may persist for 3 months approximately. After 3 months, acute illness IgG and anti-HEV may be present. The presence of HEV RNA in serum and stool accompanies acute infection. Viremia resolves as a clinical biochemical recovery and shows, while HEV RNA in stool may outlast viremia by several weeks. Coming to the prognosis, it is self-limited disease. Mortality is around 1 to 4%. Mortality is approximately 20% in pregnant women. Transmission of HEV from pregnant mother to fetus can result in fetal demise. No treatment is available. Prevention, it is GlaxoSmithKline has developed a HEV vaccine. Double-blind study, 2000 adults, 95.5% efficacy and minimal adverse events, but it is not commercially available. It is estimated that 15 million people carrying hepatitis B virus worldwide are infected with hepatitis D. Hepatitis D is common in some areas of the world with high burden of hepatitis B infection. Outbreaks of hepatitis B with high mortality have been reported in native Indians of Amazonia basin. HDV virus can be transmitted through contaminated blood or sexual contact of a carrier. However, sexual transmission is less effective than parenteral exposure, and HDV infection is not common in HPV positive homosexual men. Family contact among HPV carriers is another risk factor for dissemination of HPV. Hepatitis D infection can occur as a co-infection or as a super-infection in individuals infected with HPV. Co-infection with HPV and HDV often lead to more severe form of acute hepatitis. Super-infection with HDV occurs in individuals chronically infected with HPV, accelerating the course of the disease and causing overt disease in asymptomatic carriers. Jaundice and increase in liver enzymes may occur as soon as HDV super-infection. Prognosis and severity of HDV superinfection is worse than HPV infection alone. Mortality rates in superinfection is between 2 to 20% of the cases. Due to the severity, most of the hepatitis D cases do not remain unnoticed. Among all cases infected with HDV, acute infection, co-infection occurs in 1 to 3%, while superinfection reaches around 80% and more. Diagnosis of acute HDV infection is based on serological test for anti-HDV IgM, HDV RNA or HDHAG. Acute HDV infection is usually self-limited, thus markers often disappear within few weeks and can be undetectable in some instances. HDV superinfection in chronic hepatitis B may lead to suppression of HPV markers during acute phase, presenting serological tests with positive results for HDV but negative for HBV. HDV antigen is usually cleared, however HDV antibodies can persist for years. HDV RNA is also found in serum of super-infected patients. HDV antigen are detectable in the liver, however they are not always observed in the blood. Treatment with interferon for 6 months or more improves patient's condition, however relapse is common when treatment is stopped. Prevention measures for HDV are similar to those used for HPV. Immunization against hepatitis B protects against HDV infection. The problem in HDV protection for those already infected with HPV. In HPV infected areas, the only effective measure is avoid exposure to HDV sources. Specific immunization against HDV and HPV carriers is under development based on HDV antigens. Counseling to avoid high-risk parental or sexual exposure among HPV carriers is an effective way to prevent spread of HPV-HDV infection.